All right, let's talk about pneumonia. We're going to walk through the entire clinical story from the moment the infection first invades the lungs all the way to the path to recovery. The goal here is to make this stuff really stick so you'll have it ready when it counts. So let's jump right into a situation where every single second matters.
Okay, picture this. You've got a post-operative patient, their vitals are stable, everything seems fine, but then, out of nowhere, they become restless and agitated. So, why does that immediately shoot to the top of your priority list? Tuck that question away for a minute, because the answer is one of the most important things we'll cover today.
To really get why that scenario is such a massive red flag, we first have to understand the enemy. So what exactly is pneumonia?
At its very core, pneumonia is an infection that kicks off this huge inflammatory response inside the lungs. Think of it like an invasion. This invasion makes those tiny little air sacs, the alveoli, fill up with all kinds of gunk, mucus, fluid, cellular debris. And what happens then? Well, their main job, gas exchange, just grinds to a halt. CO2 can't get out, and more importantly, oxygen can't get in. And that leads directly to hypoxia, which is a dangerous lack of oxygen in the body.
Here's a quick and easy way to lock that in. Just think of the P in pneumonia as standing for plague. It's like a plague of infection that spreads through the lungs, and it completely overwhelms the body's #1 system for getting oxygen.
So, the invasion is underway. How do we spot it? How does the body sound the alarm bells to let us know that something is wrong? What are those classic signs that tell us pneumonia is taking hold?
The body's response is actually pretty loud and clear if you know what to listen for. You'll usually see a productive cough with some yellow-looking sputum. That's basically all the debris from the infection getting coughed up. A fever over 100.4 is a dead giveaway that the immune system is in fight mode. Patients will often describe this really sharp stabbing pain in their chest when they breathe in. That's called pleuritic pain. And of course, because that gas exchange is so messed up, they're going to feel short of breath. Then, when you listen with a stethoscope, you'll hear these fine or coarse crackles, which is literally the sound of air trying to bubble its way through all that fluid in the alveoli.
And this right here. This brings us back to our opening question. This is absolutely critical. The #1 sign of low oxygen, of hypoxia, is not gasping for air. It's altered mental status. You see, the brain is an oxygen hog. It's incredibly sensitive to low O2 levels, so when it starts getting deprived, the very first signs are things like restlessness, agitation, maybe some confusion. That's why your post-op patient's sudden agitation is a top priority. It's a massive alarm bell screaming hypoxia.
So, that altered mental status is a huge clue. But a hunch isn't enough. We need to confirm our suspicions. How do we go about making the official diagnosis and, just as importantly, identifying the specific invader we're up against? Well, one of the first clues comes from the blood work. We're going to see an elevated white blood cell count, usually popping up over 10,000. This is a clear sign that the body's immune system has sent out its soldiers to go fight an infection. It basically confirms the battle is on.
All right, pop quiz. This is a common board-style question. For a patient who's on a ventilator, what is the single best indicator that they've developed VAP, or ventilator-associated pneumonia? The answer? A positive sputum culture. You know, a fever and changes on a chest x-ray are important clues for sure, but the sputum culture is definitive. It's the smoking gun because it actually identifies the specific organism that's causing all the chaos. It puts a name to the enemy.
And this highlights a golden rule of engagement in medicine. You must always get your cultures, whether it's sputum or blood, before you start the antibiotics. Why is that so important? Well, if you start the antibiotics first, you might kill off or suppress just enough of the bacteria that the lab can't figure out what it is. To pick the right weapon, you have to know who you're fighting.
Okay, so we've identified the enemy. Now it's time for the battle plan. How do we fight back and support the patient? Our treatment playbook really comes down to two main objectives.
First, we got to get all that fluid and gunk out of the lungs. We have to mobilize those secretions. That means repositioning the patient every 2 hours to keep things from just sitting and pooling. We're going to increase their fluid intake to help thin out that thick mucus. We'll use chest physiotherapy to help loosen everything up, and we'll teach them the huff coughing technique so they can clear their airways more effectively.
Second, we need to get those lungs to open back up and expand. We'll encourage them to use their incentive spirometer every hour. We're going to push for early ambulation. Getting them up and moving within 8 hours after surgery is so important. And of course, there's the classic turn, cough, and deep breathe, all while keeping the head of the bed up high to give the lungs plenty of room to inflate.
Now here's a fantastic pro tip that's simple but incredibly powerful. If a patient has pneumonia in just one lung, you should position them with the good lung down. This little trick uses gravity to your advantage. It sends more blood flow to the healthy, working lung, which can dramatically improve their overall oxygenation.
So what happens when the battle takes a turn for the worse? We have to be able to recognize the really dangerous, life-threatening complications that can pop up if the pneumonia is severe or if our treatment plan isn't quite enough.
The first major complication is called a pleural effusion. This is when fluid starts to build up in that little space between the lung and the chest wall. This fluid basically squeezes the lung from the outside, which prevents it from expanding all the way and makes breathing even more difficult.
Next up is ARDS, which stands for Acute Respiratory Distress Syndrome. And remember that memory trick? ARDS sounds like HARDS. That's because the lungs become incredibly stiff and hard. The defining feature of ARDS is something we call refractory hypoxemia, which means that their oxygen levels stay dangerously low even when you're giving them 100% oxygen. It's a very serious sign.
And the final, most deadly complication is septic shock. This is when the infection escapes from the lungs and invades the entire bloodstream. The body just goes haywire, launching a massive, system-wide inflammatory response that causes blood pressure to plummet and can lead to multiple organ failure.
Recognizing septic shock means knowing how the signs evolve. Early on, you see the classic signs of infection, a high fever, a high white blood cell count. But as the body starts to fail, you see this terrifying shift to the late signs. Their temperature actually drops. They become hypothermic. Urine output decreases as the kidneys start to fail. And the hallmark sign is a systolic blood pressure that drops below 90. Okay, so after that critical battle, how do we actually win the war? Let's look at the path to a full recovery and, just as important, how to prevent this from ever happening again. Winning the war really comes down to patient education. They absolutely must finish their entire course of antibiotics at home, even if they start feeling better. They need to schedule a follow-up chest x-ray to make sure everything's cleared up. To prevent it from coming back, the pneumonia vaccine is key, along with non-negotiable habits like good hand washing and quitting smoking. And most importantly, they need to know to report any worsening symptoms right away.
And that brings us full circle. We've seen the entire story of pneumonia, and we know that immobility, just lying still in a bed, is a primary risk factor. So what's the single most important preventative action you can take for your next post-op patient? It's early ambulation. Getting that patient up and moving isn't just a task to check off a list. It's the critical intervention that can prevent this entire dangerous cascade from ever beginning.